Kueht. My name is Michael, and I'll be today's host. To introduce Dr. Kueht, he's an assistant professor in transplant surgery at the University of Texas Medical Branch, or UTMB, in Galveston, Texas. He earned his MD at UTMB and completed internship and residency in general surgery at Baylor College of Medicine in Houston, Texas. After residency, Dr. Kueht completed an abdominal transplantation fellowship at Baylor College of Medicine. Dr. Kueht is a researcher focused on liver disease and surgical risk stratification, as well as outcomes in abdominal transplantation, with authorship for over 45 peer-reviewed articles. A couple of reminders before we begin. We encourage you to turn on your cameras if you're able to. This session will be recorded and uploaded to our YouTube channel, and there will be a Q&A session at the end. You can unmute at that time, or feel free to write your questions in the chat at any time, and we'll cover them during the Q&A. But with that said, Dr. Kueht, feel free to take it away.
Okay, thank you very much. That was about half of my presentation and introduction, so we can skip to it. As he said, so medical school actually comes in two flavors, right? I went to allopathic medical school, so I have the MD behind my name there. And I work at UTMB, hence UTMB all over the place on my slides, as a transplant surgeon. Liver, kidney, pancreas. Let's put that little dealie up there so you can see in case you forget. But today we got to focus on something, and we'll talk about liver stuff. Let's see. I can even change the slides. All right. So since I default and talk about liver disease usually, hold on. Yes. There are children here. So the, I'm sorry. So the liver is awesome for many reasons, as you will learn. The more you learn about it, the more awesome you will know it to be. Here are some of the things on the left screen that the liver does. It's super duper important, to put it one way. This is literally just a fraction of the things that it does. Square it away, hon. It participates in all of the bodily functions, even ones that you don't associate normally with the liver. Hey, can you turn the light back on? All right, so gluconeo, I misspelled it right. So gluconeogenesis. So there's some of the ones that you know about, that like you've known about since you were young. It produces bile, right? Everybody knows someone who's had their gallbladder removed, which is the storage place for bile, which helps you digest food. It creates clotting factors. So as in your studies, you'll learn about the coagulation cascades and how central is the liver to that. It's kind of weird because it's like a GI structure, you know, and yet if you don't have it, your blood gets too thin, you hemorrhage out of your eyeballs. It's horrible. It also participates in energy regulation through several ways. Gluconeogenesis, we think that the muscles, skeletal muscles, right, store glycogen, utilize glycogen and glucose and glycogenolysis and all of that. But the liver does legitimate gluconeogenesis from lactate and amino acids and other things so that the body can utilize the sugars. It creates a whole host of proteins. Central is albumin. Albumin is like the human protein, right? It's the most abundant protein measured in the blood, comes from the liver, does all sorts of things. It's like the nature's most negatively charged biological molecule, and it does all sorts of things related to its charge and its complex structure. Lots of things are metabolized to the liver, drugs. All medicines have to be broken down some way, somehow. A lot of them are done in the liver through the cytochrome P450 system, and we'll kind of talk about that. I heard that. Cholesterol regulation, right? So everybody nowadays has cholesterol problems and those on anti-cholesterol medicines such as a statin, and those work through the receptors in the liver, actually. So that's why we say that you don't need any dietary cholesterol, right? You can get everything endogenously, and that's probably true. And some other crazy things that you don't know. Thermoregulation. It is such a large organ. It takes up 1/3 to 1/4 of your abdomen, depending on your age. And all of the metabolism going on in there, and probably some hormones that it secretes help regulate your body temperature. So that when you have liver failure, right, that's that nasty liver there, you have problems with all of these things. So you are in trouble when you have liver failure. You don't have bile, right? Turn yellow. Can you close that? Thank you. And all of that. Not right now. Get out of here. Please. There are 3 of them, and they're taking turns coming in. Okay. And the things on the right of the screen are the things that cause liver failure. Some of the things. Okay, probably not necessarily in the order that is most common, right? Most common worldwide is hepatitis B, as in beta, but not so in the US, because vaccination to hepatitis B has become standard. Before you leave the hospital when you're born. If you're born in the hospital, you get hepatitis B vaccine before you leave, because we know that it works and it's preventable, and hepatitis B is bad for you. Kind of like this COVID vaccine, I guess. Except for hepatitis B has been around for longer, but not that long. Not that long. When we systematically began vaccinating people against hepatitis B 20 years ago, right? Oh, throughout 30 years ago, the 90s. That's it. That's one lifetime, you know. Hepatitis C, for which there is no vaccine, but there is now a treatment, used to be the scourge, untreatable disease. You had to take horrible drugs to make you feel like you had the flu for a year at a time, and it only worked 50% of the time. Now there's a pill you take once a day for 12 weeks or 8 weeks, 8 to 12 weeks. Almost no side effects, 99-point-something% chance of cure. It's like the closest thing to a guarantee in medicine that we have nowadays. Alcohol, everybody may have heard, and if you haven't, FYI, you can drink so much that your liver goes bad, and that normally takes decades to do, although if you try really hard, you can probably do it in a short time. Toxins, sometimes you might hear about anecdotes of plastic or rubber factories, and also moldy wheat, aflatoxin and stuff like that. Not very common. Autoimmune diseases such as autoimmune hepatitis, also less common, but they exist. One that's common, I'll show you some slides on there, is fat. Fat in your liver is bad. Fat in your liver replaces the things, the hepatocytes, or pushes them out, and the hepatocytes are working, the fat is not, and then it decreases your liver function to the point where it can become kaput. Congenital reasons, so some babies are born with liver problems, little guys. Congenital absence of the bile ducts, like biliary and associated conditions, where they didn't stand a chance and they need to have the liver replaced. Point is that kind of drew this cartoon on here because A healthy liver, which is nice, smooth, has sharp edges, is soft, but not too soft, and has this maroon color, can go into this hard, nodular, rounded edge, yellowed thing through chronic injury. And when it reaches a certain stage, it cannot go back. This condition is called end-stage liver disease. Cirrhosis is one of the descriptions of it. And the point is that there's no reversal for it. There's liver replacement, such as, which is liver transplant, but there is no dialysis, which is a replacement for kidneys. There's no insulin, which is a replacement for diabetes. There's no heart pump equivalent. Excuse me. There is there's no currently available organ replacement therapy besides organ replacement for the liver. Keeps us in business. Okay. This may be, so I'll just kind of walk you through sort of what this is. So on the left, that's histology. Those are biopsies. So looking under the microscope at 100x or more. And you can see the top left is the normal liver. You don't need to be a pathologist to be able to describe histology. So you know, you could do it now. As long as you relax your mind, you look at that and you say, it's kind of pink. Yep, that's right. And it looks like the cells are kind of organized almost in a uniform way. That's right. And looks like there's some kind of area in the top right portion of that little picture. Looks like it has some circles in it. And it's kind of shaped like a star sort of thing. And I'm like, yep, that's right. And the cells looks like those look like they're kind of a maze pattern that kind of goes through them. It's kind of like lines here and there. That's right. That's what normal liver tissue looks like. The little lines things. Those are the sinusoids. The little star thing in the top right is the portal tract, has the bile duct, portal vein, and hepatic artery in it. And those pink things are the hepatocytes. They're all nice and uniform and organized. Now, this is kind of a stepwise thing going from top left to bottom right. Next step down, you start to see circles that are white. They're kind of like they weren't there on the other one. And indeed, those are fat droplets. Okay. And NAFLD is non-alcoholic fatty liver disease. Okay. Which means that there is fat in the liver, but not a lot of inflammation. So this is the early stages, right, where it's reversible. The body's natural ability is to store fat in the liver. It doesn't need to usually, but it will if it's forced to. It's trying to help you out. But then when the fat stays around too long, the body starts to react to it. Sends in the white blood cells, right? And then there's inflammation. White blood cells go in there, but there's not an actual problem. There's just a normal situation in excess. Things get all cattywampus and out of control with inflammation. That's what blood cells do, cause inflammation, then clean it up, hopefully, to reveal a new and improved tissue. Well, there's no cleaning this up because it's an ongoing process. And so that's called NASH, non-alcoholic steatohepatitis. So non-alcoholic, that's pretty self-explanatory. Steato, fatty, hepatitis, right? Itis, inflammation, hepa, liver inflammation, non-alcoholic fatty liver inflammation, non-alcoholic steatohepatitis. Reversible. Remove the ongoing insult, the inflammation will subside. NASH with F2, F3. So that's F is fibrosis. And that means that the inflammation has gone on long enough that it causes scarring. Scarring is irreversible, kind of. it's bad, that's for sure. And when the scarring reaches a certain point, then it is most definitely irreversible, and that is called cirrhosis. And the key word there is bridging fibrosis, and it means that the fibrous tissue, the scar tissue, has connected the portal tracts and created basically locked in segments of the liver. And you can kind of see that right there. There's like an island of pink stuff surrounded by this gray-blue stuff, and that is cirrhosis. So even if the liver wanted to regenerate, it actually has stem cells, super cool. It will regenerate unless there is bridging fibrosis as an impediment. That is the picture of end-stage liver disease for which you need liver replacement via liver transplantation. It's not going to get better. It's going to get worse or stay the same. Whereas the middle two are possibly reversible states. The last one is not. Okay, that was cool. So this is interesting, is that, and depressing. On the right side of the screen, these are the indications for liver transplantation over the years, or by era. Okay, the early 2000s, hepatitis C was the most common, right? And fatty liver disease was relatively uncommon. As you can see, hepatitis, I gotta move my thing here a second. Hepatitis B, these are in America, has kind of stayed the same because it started about 10 years prior to that, and it's pretty effective. Alcoholic liver disease and NASH, however, have been going up. NASH almost exponentially, alcoholic liver disease steadily, whereas hepatitis C is going down. So we treat one, then the transplantation becomes the other. Right now, there's not a good treatment for NASH besides losing weight, which, as you know, is difficult in the obesity epidemic. And alcoholic liver disease, well, you don't have to tell on yourself, but you know, drinking is fun. Okay. So what do we, that's good. What do we know about ESLD, end-stage liver disease, cirrhosis, when your liver goes bad? Well, this is how you know when someone's liver goes bad. It turns yellow, condition called jaundice. And that is because the bilirubin, the bile, is not able to leave the liver, backs up into the bloodstream. Bile is yellow, turns your whole body yellow. Doctors use the fancy term hyperbilirubinemia, emia, blood, bilirubin, hyper, high bilirubin in the blood, okay? And that's also a condition called cholestasis. Chole relating to bile, stasis not flowing, right? All right, people turn yellow when they have liver disease. Coagulopathy, your blood gets thin because the liver is involved and important in making circulating clotting factors. Specifically, 2, 7, 9, and 10, and a few others. Actually makes anticoagulating factors also, right? It's a check and balance in the coagulation cascade. And those are protein, CNS, and antithrombin 3. But it's not making those either. So, so you get all wonky, right? You get all out of sorts with regards to your coagulation. And that's manifested multiple ways, one of which is an increase in the lab value, which is called INR, which is the International Normalized Ratio, which is the way we report the prothrombin time now, the PT. Anyway, blood doesn't clot as well. We measured it through the INR. When your INR is high and your liver's not working, it means you're in trouble. It can be a chronic condition, but you're in trouble. Okay, and then there's this other thing called portal hypertension. Okay, the liver is, do I have a, okay, the liver, if you just look at the right side of the screen for a second, its blood, one of its blood supplies is the portal system, which is the blood from the bowels. You eat something, goes into your mouth, into your stomach, into your intestines. Then it's absorbed into your intestines. Then where does it go? Well, turns out that it's a mandatory customs check at the liver. So it goes into the bloodstream, into the portal system, goes into the liver. And there, all sorts of things happen. But when that system gets blocked up because the liver is fibrotic and cirrhotic, you get all sorts of problems with the blood flow in that area. And it's manifested in changes in your electrolytes, such as hyponatremia, low sodium, sodium, blood, low blood sodium, thrombocytopenia. Thrombocyto means platelets. Penia means low, right? Low platelets. Hypoalbuminemia and elevated creatinine. Don't have a fancy term for that. Or if you do, you sound silly when you say it. Also, some of the problems that you can notice in folks who have liver disease is they develop ascites, which means fluid in the belly. And that is a miserable state. The blood that was, you can think of it, maybe some of you are engineers, as a simple, the liver, and Ohm's law, right? V equals IR, where the voltage, right, is the difference across something, in this case, the liver. The I, the current, is the portal blood flow, and R, the resistance. Normally, the liver is a very low resistance system. And when the resistance in that system goes up, the current backs up, the difference across the liver, the voltage goes up, and you get built up on one side. And then the fluid is, blood is made of fluid, you get ascites. Okay, you get brain foggy, you get blood where it's not supposed to be in previously happy blood vessels. Those are called varices. The spleen gets big. That's bad for you because it eats up your platelets. And then your kidneys fail. Man, you're in bad shape if your liver's failing. Okay, move this sarcomere here. Oh, yeah, not to mention you waste away before your eyes despite eating everything in sight. You have hypogonadism due to abnormal estrogen metabolism. Hypoaldosteronism gets you low blood pressure. You have hypovitaminosis. You're in bad shape. Can we summarize and say that? I think we can. Then we look for these things in people, right? And when people have portal hypertension, that's bad. You can have liver disease. You can have varying degrees of liver dysfunction. You can even have cirrhosis without portal hypertension, and those people look fairly normal. If and when, however, they develop portal hypertension, they no longer look normal. Those people are sick. And there's not a good cure for portal hypertension except for replace the high resistance part of the circuit, which is the liver. There's a couple ways you can short circuit the system. It's called a TIPS, and the radiologist does a short circuit inside the liver, transjugular intrahepatic portosystemic shunt. And that way they bypass the liver and the blood can get out of the portal system into the systemic circulation. But it doesn't fix the problem. None of the other functions of the liver are improved with that. Matter of fact, they probably get worse. So when you look at these folks, they have ascites. How can you tell if they have ascites? Well, they're big, right? Well, how do you know it's just not, they're not fat? There's this thing called shifting dullness, right? So when they're laying on their back, there should be a little bubble at the top. And when you percuss on the sides, dull, 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 dun, 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 tympanitic. Tympanitic, dull, 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 dull. Bubble. You're like, huh, okay. Then you lay them on their side and the bubble should go up, shifting dullness. Then the presence of varices. Varices are abnormal blood vessels. They're manifested in the physical exam in discrete places. That's really why I put this picture on. And caput medusa. That's a cool term, right? And that's the head of Medusa, right? And Medusa is in Greek mythology, head of snakes. And indeed, that's at the umbilicus, right? They have these spreading veins coming out in the subcutaneous area. And it's gotta be pretty bad to see it well, but you can definitely see it sometimes. And then esophageal, right? You know, these people throw up blood. It's horrible because esophageal, these varices are not normal blood vessels. So they're likely to leak. When blood vessels leak, that's called bleeding. And then hemorrhoidal, right? So you're just bleeding out of your everywhere. Oh, good Lord, it's bad. These people get radiographic studies, right? CT scans. I don't know who here has ever been to the ER, but you probably got a CT scan if you were complaining enough. And if you didn't, you weren't complaining enough. The presence of ascites, you can see fluid in the belly. It's usually simple fluid as measured by a CT scan. You could actually look at the portal vein. It says it's big, it's a centimeter. It's normally supposed to be half a centimeter. And you can see these varices and you look for them in the expected location because you're smart. And that's how you find them. And radiologists who are not looking for them may not find them. FYI, future radiologists, don't screw it up. Okay, so what about surgery and people with liver disease? So we know who is dying, right? They look like they're dying. And people who are, one second here, not dying, the question is, if they have liver disease, what can we do with them? Well, sometimes they need surgery. Sometimes people with liver disease need surgery. And sometimes you're forced to do so. The general dogma with people with liver disease and surgery is don't do it. You know what I mean? Find some other schmuck who will do it. But sometimes the choice is between performing surgery and a fatal condition, and you have to risk the surgery. Okay, we measure the degree of liver disease with the MELD score. There are many ways to do it. And nowadays we do it with the MELD score, a model for end-stage liver disease, developed at the Mayo Clinic up in Rochester, Minnesota, where it's very cold. And it's pretty simple. There's all this math in here, but really the key is that there is a multiplicative factor for the INR. There's a multiplicative factor for the creatinine. And there's a multiplicative factor for the bilirubin, or the natural log of them, but still you get the point. Is that it's very simply, it's a regression equation developed from people who are sick and then normalized. It ranges from 6 to 40. Right now, I'm about a 10. I'm just kidding. I hope I'm about a 6. And then they threw in 2016, I think, or 18, they threw in the serum sodium because they found out that folks with hyponatremia did worse. Not probably because the sodium is low, but because it's a marker of something. And that's how we do it. And if the creatinine, which is a measure of kidney function, is if they're on dialysis, then it maxes out at 4. Okay, so what happens when you're forced to do surgery on these people? Well, as expected, they have issues. So at the top of the screen here was the effect of adding the serum sodium to the MELD score. And you can see the red bars, everyone is clustered in this particular cohort. Everyone is clustered around 11 to 15, shifted to the left, the distribution is. And when you add the sodium, it actually draws out the distribution into the higher MELD scores. So people who we thought were a 15, when you add the MELD score in the new system, they actually turned out to be maybe a 20. And we had to adjust the way we thought about things. Well, let me just make this simple here, is that on the bottom of the screen, there's a table from the paper. And on the left of that table are the MELD score categories. 0 to 10, basically a normal person. 11 to 15, they have cirrhosis, but probably not severe. 16 to 20, they have bad cirrhosis. And 21 to 40, they got really bad cirrhosis. What happens to these people? Well, you see the red box there. They need blood transfusions during surgery. They bleed a lot, and they bleed a whole lot when the MELD score gets above 20. They have issues with their blood pressure and their heart situation, purple box, as evidenced by the need for medications to keep the blood pressure up. And that shows a spike even in the moderate range. They have infections. One of the things I left out, a function of the liver, is that it participates in the immune system. It's a big contributor to the immune system. It creates complement, which helps opsonize bacteria and act in one of the early activators of the immune system. So they get bacteria in the blood, bacteremia, pneumonia, PNA, urinary tract infections. Usually that's because you have a catheter in after surgery. Then they have issues with breathing, reintubations. They need trachs, tracheostomy, and they need the breathing machine for a long period of time. Then they go into renal failure. It's a mess. So the point with this is that all of the functions that we know the liver does, when the liver has cirrhosis, when you are in homeostasis, right, relative homeostasis, you can exist. And when there is stress applied to the system, just like all other scenarios, when there is stress applied to the system, the excess goes away and you get into trouble. So you may not, your blood is thin, right? Maybe you know someone who's on Coumadin for AFib, maybe a parent, maybe a family member, and their blood is thin. We did it on purpose, but they're not bleeding all over the place. But if they had to have emergency surgery, it would be difficult. Similar situations with the liver. The blood is thin, but until the system is stressed, there's no real problem. But these are just the complications, right? Death is also fairly common in these folks. You can look at the paper, but these are just some highlight of some of the things that folks who have not had their liver replaced need. And I think it's kind of fun to look at some of these. Okay, so check it out. These are some patients. All right, so how are we going to organize this? Okay, on the right, some imaging. There's a CT scans. The top one is an axial view, right? Spine at the back, belly button at the top. That liver is the big thing that's shaped like a teardrop on the left side of the screen, which is actually the right side of the patient, hence the R and the L. And And then the picture on the bottom is the coronal section. Coronal like this. And similar orientation with the right and left. All right, there's some lab values in the middle. There are some hematologic values, white blood cells, hemoglobin, platelets. So interestingly, we measure the white blood cell concentration, but we don't really talk about the red blood cell count. We talk about the hemoglobin. And I'm not exactly sure why. Hemoglobin or hematocrit, which are, you can derive either from either. We measure the platelets there, INR right there. It ranges from 1.0, which is normal, and then goes up from there. I don't know if there's an upper limit. Serum sodium and milliequivalents per liter, a concentration. Total bilirubin, also a concentration in the blood, and the creatinine, also a concentration in the blood. So I did the math for you, don't worry. MELD score is 12. As you remember from the previous slides, it ranges from 6 to 40. So that's like, you know, not perfect, but the dude's probably got some liver disease here. Why do we think he has liver disease? Well, he's 55. And if we look down the past medical history there, he's had hepatitis C for 10 years untreated, which is a risk factor for liver disease. 10 years is actually probably not enough with hepatitis C to draw you into cirrhosis or a bad cirrhosis. But he shows up with an incarcerated umbilical hernia. Dude, his hernia is stuck. What are you gonna do? Here's your options. Fix it, do something and then fix it, or just sentence him to death and say that's too risky. Those are the options. Well, how we would tackle this situation is we'd look at everything, right? First, we'd look at him. Did we look at the blood work? Then we look at the imaging, and then we make our risk assessment. This dude needs help. And all the other hospitals around are full. We can't even transfer him, even though we really want to. Okay, so look at the imaging. The liver actually looks pretty normal. It's not the perfect liver, but it looks pretty normal. Take my word for it. So that's reassuring. And then we would have looked for all those other things we said about the presence of portal hypertension. Then we look at the labs, calculate his MELD. MELD is like, okay, I've seen higher. And then really the only thing abnormal on this is a T-billy of 1.6. Everything else is pretty normal. So we say, you know what? Fix your hernia, dude. We're going to hope you do well. Now his liver can get worse. Folks with cirrhosis don't necessarily tolerate insults the way folks without cirrhosis do. But he has a pretty low chance of, he has a high chance of something bad happening if we don't do something, and a fairly low chance of something bad happening if we do surgery. Fix him. Oh, wait a minute. Still a 55-year-old male, still presents with incarcerated hernia, still has hepatitis C for 10 years untreated. However, things have changed. All right, the CT scan looks different. Don't you agree? Let's see. Oh, that's bad. That, my friends, is a bad CT scan. You know, whatever your philosophy is, or things, nothing is good or bad, that's bad. All right. Okay, so that liver is bumpy. It has a nodular contour, which is found in cirrhosis. The bottom screen with the coronal view, that gray stuff floating around in the abdomen, that's in between black and the color of the liver gray. So it's like a dark gray. That's all fluid, okay? It's not, air is a stark black, and contrast is, and bone is stark white on CT scans. And everything else in between is something else. So the liver lights up a little bit and the fluid doesn't light up very much. The dude has ascites. And then if you look at the top one, the axial view, the blood vessels look a little different than the last one. Let's go back there. All those blood vessels are like inside the liver. And this one looks like it's kind of like outside the liver. And that is radiographic evidence of portal hypertension, a recanalized umbilical vein. The umbilical vein is a fetal remnant structure. You need the umbilical vein when you're a fetus and you don't eat, right? The umbilical vein provides access to your body, bypassing your guts, so that blood from the placenta can get to your heart and your circulation. You don't use your bowels when you're in utero. And it turns into a little fibrous band that once was a blood vessel when you grow up. However, when there is sufficient resistance within the liver into which it hooks, the blood can actually back up into that system, recanalize it. That's how you get kaput medusa. And that goes to your umbilicus. Anyway, and you see it like that on the CT scan. Bad CT scan. Labs, let's see how the labs, white blood cells the same, hemoglobin is the same, platelets are lower, INR a little bit higher, sodium a little bit lower, total bilirubin a little bit higher, creatinine a little bit higher, giving us a MELD score of 22. Now we're in the danger zone. This dude is going to have issues. However, hopefully we can fix his incarcerated umbilical hernia without killing him. He is likely going to have complications that we're going to have to deal with, and you're going to have to tell him about afterwards. Uh-oh, same CT scan, same patient, different labs. Now the white blood cell is 20, white blood cell count is 20. Hemoglobin is low, anemic, leukocytosis, anemia, thrombocytopenia. When you hear those together, you're like, dude, someone's in trouble. INR high, wicked high. So INR is normalized ratio. So we could say that that's about 3 times, blood is about 3 times as thin as normal, or thinner than normal. Hyponatremia is a bad sign. Hyperbilirubinemia to the 6s is bad, and the kidney function is bad also. MELD score of 38. Almost doesn't get any higher than this. This guy is showing systemic signs. This guy's in trouble. Need to counsel him that even if we fix his hernia, he's possible that he'll die. That's bad. Let's fix a little hernia about this big. It's probably like this in him, but when you have liver disease, it's bad for you. Oh, what about this one here? Let's see what changed between these two. Scenario 3, scenario 4, only the age changed. So now this is a 75-year-old who has advanced liver disease and is in trouble. And they present with a problem. Now, there's no right answer, I would say. You have to look at them, have to talk with the family and say, the likelihood that you will die during this hospital admission is real. It is as high as 60%. The likelihood that you will die if we don't do anything is high. It is 99%, probably 99.9, depending on how big of a role you think miracles play in life. So this is what we do. So and we came up with some numbers here. These are general guidelines. Point is that risk of complications, right, not going as planned, extra stuff needed, happen in the low teens is when the cutoff starts taking off. And hazard ratios, I don't know how much statistics you guys do, but hazard ratio, you can use that, the horse track, or you can write papers with it. And it's basically a relative risk assessment of an event happening versus a reference group. And you can basically say 3.5 times more likely, 3 times more likely, or in this case, less likely to go home. So the odds go up quickly, even with relatively minor liver disease. However, cirrhotics need surgery too, which is the problem. You know what I mean? You can get if the mortality is 60%, that means 40% of the people you may be able to get through. And there's some extra factors that play into who is and who is not going to live. And then talking to the people, that's a big part of what we do. We're like, listen, man, you got a big problem. We're definitely going to try to fix it. But even if we fix this problem, the likelihood that something else is going to creep up is pretty high. And the idea here is that liver transplantation has a safety net. So if their liver disease gets worse, then we can switch it out for them. Not as easy as it sounds, but that's why patients with cirrhosis should ideally be treated at places where liver transplant is an option, because if you get into trouble, there's only 2 options: liver transplant or death. And that sucks. All right. We got kind of heavy there at the end, but that's kind of the deal. So that's what we do. We deal with real problems in real people, and it's not always easy. And there's infinite room for learning. And so you should come do transplant surgery with us. All right, that's all I got.
Thank you so much, Dr. Kueht, for your presentation. Really informative. I like the case reports and how you compared the ages, just like kind of isolated the variables there with ages. Right now, I guess we'll go on with our Q&A session. So if anyone has any questions for Dr. Kueht, feel free to either type it in the chat or unmute yourself right now.
And you're gonna questions, Michael, or?
I don't have any questions off the top of my mind, but we do actually have one question that came in. What is the most complicated surgery / case that you have worked on?
All right. Well, they say that liver transplantation is probably the biggest abdominal operation you can get, because liver is so important and you're in such bad shape basically by the time you need it replaced. And when there are extra factors involved, then it exponentially increases the difficulty. So I would say the hardest surgery is a redo liver transplant. So those are folks that have had a transplant, usually for a while, the idea is, and then something happens to that liver as well. We didn't get into all of that stuff, but rejection, secondary biliary cirrhosis, all sorts of things can get the new liver. Not very commonly, but they can. And when you have to put in a second liver, when there was already a liver in there, let's just put it this way, that whoever put bodies together originally put it together very elegantly, and it only likes to be taken apart once. So when you go back in there after man has rearranged things, all the scar tissue makes it incredibly difficult and dangerous. and there's only a 50% basically chance of making it out of the operating room. So I would say redo liver transplant is probably, well, if we want to qualify, redo liver transplant for secondary biliary cirrhosis is the one. You can look up all those words if you want.
Yeah, so each kind of physician that we meet with and does a shadowing session with us, they have their own kind of journey that brought them to their own field. So for you, what got you interested in liver and transplant surgery?
Oh man, thanks. I actually, on the other slides, I had a couple of things, but anyway, so as you said, I went to, maybe you didn't, undergraduate at the University of Houston, in Houston, and it's funny because there's more than one university in Houston, but it's the University of Houston anyway. And while I was there, I actually studied exercise science. That's what I graduated with a degree in. And I got roped into immunology. So the immunology of exercise and things like that while I was there. And I did some bench research with one of the professors in undergrad. And then I kind of kept up. I realized they tried to talk me into doing a PhD. And I'd say, oh, do a PhD, you know, be a real doctor. That's what they say. I said, I'm going to do MD and be a real doctor. But one of the reasons why actually I chose the medical field or medical school is because you can do research and take care of patients. Whereas if you have a PhD, you're not allowed to take care of patients. Sometimes I regret that decision because taking care of patients is hard, you know, emotionally and mentally and all that stuff, and physically sometimes. But there's nothing more gratifying, right? So you can keep going and all of that. And research is not very easy either. So anyway, I decided to eventually go into surgery and marry the fields of immunology and surgery. And hello, transplant is awesome. I think it kind of is obvious why anyone would want to go into it. And that's me.
Sounds good. You referenced a few times about MELD scores along with the patient cases. Are there other scores just like MELD for conditions of other organs?
Well, yeah. You can just call it the MELD score if you wanted to sound cool. Let's see. Kind of. The liver probably has one of the most complex set of functions out of any of the organs. Everyone who studies or deals with a particular organ will tell you that that is the most important organ in the body. The nephrologist is going to tell you it's the kidney, cardiologist is going to tell you it's the heart, pulmonologist is going to tell you it's the lung, urologists are going to tell you it's the bladder. No, they don't say that. But really, there are similar scoring systems for the degree of organ failure. So the New York Heart Association classification for heart failure, right? Heart failure grades 1, 2, 3. Really, that's just how much of each symptom you have. So I would say nothing actually compares to the multitude of functions of the liver as measured in the MELD score. People love making scores, okay? And the MELD score, believe it or not, it works pretty well. And we talk about it a lot. It works better than most things we have. But it's actually just a handful of factors. Turns out that you can increase the sensitivity, let's just say for death after a TIPS procedure or death on the wait list for transplant by adding factors to that score. You can add the degree of protein malnutrition. You can add the age. Notice it doesn't have the age in there. You can add A few things. You can add all sorts of things. Matter of fact, it originally had 16 factors in it. And they were like, wow, that's a really complicated score. They shortened it down to 3 factors and they only sacrificed something like 1/10 of a point of the C statistic. So it's operating out there with about an 83% positive predictive value for various indications, which is decent. And then if you add on a bunch of things, it increases it to like 87. So lots of scores exist. And I guess the idea is that for scores to be useful, they have to be used, and they have to be used and usable. So the MELD score has kind of stood the test of time for that. So that's kind of where that lands.
All right. Another student asks, how long would the last patient who was 75 years old be recovering if the surgery was successful? And what are the common post-op complications for that surgery?
Well, I don't even have to say it. Well, let's put it here. Is that it's hard to say, right? The fact that if the 75-year-old got surgery, it would be less likely that he would leave the hospital than likely. It would be more likely that he died prior to leaving the hospital. However, if he managed to not die, the fact that he would have probably gone through the entire gamut of post-operative interventions, blood transfusions, support for the blood pressure, such as vasopressors, treatment for some type of infection because he's going to be in the ICU, and then when he gets to all of that, then this discharge home thing is an important factor that not a lot of people kind of consider. Unfortunately, there's not a lot of research on it. Well, there is in certain contexts, but so even if you make it out alive, the fact that you're still not going home, basically. And that becomes more likely in folks that have liver disease, and then probably even more so when you add age onto it. So umbilical hernia repair is usually an outpatient procedure. You come in from home, you schedule it, you know what I mean? When you're on spring break, you get it fixed, you go home that same day, you don't lift anything heavy for 3 weeks, and you're done. But it becomes something deadly all of a sudden when you add liver disease and agedness onto it.
All right. So we're nearing the end of our time. We'll have one last question. Another student asks, how does liver regeneration happen? They read up a fact that it is the only organ that can regenerate, but they don't know why.
Isn't that something? Yeah. No. So Prometheus, if you want to go back to Greek mythology, right? Prometheus, people have known that the liver regenerates since the ancient Greeks, probably before, right? Probably even Egyptians knew that at some point, probably from injuries from battle, right? But the liver, it goes something like this. In a healthy liver, you can remove 70% of it and it will grow back. As the degree of injury to the liver progresses, the amount that you can take out safely goes down. So in a fatty liver, 50% max, okay? And then the percentage goes down to all of a sudden, you want to take out as little as possible, or it's not safe to take out any. And that, so basically when that comes into play is people with liver disease who get liver cancer. You need to take cancer out, but you can't take out very much more than the liver. So some people, if they have a liver cancer and they have advanced liver disease, they're stuck. They cannot get surgery because no portion of the liver can be safely removed because they need all they can because they're hanging on by a thread. How does it work? Stem cells. So it's not, no one knows for sure, but they think that there are special stem cells that hide out in special compartments of the liver that spring into action after various stimuli and then differentiate into all of the parts of the liver that you need to. There has to be a pluripotent cell, right? Because you got hepatocytes, you got cholangiocytes for the bile ducts, you got blood vessels in there, you got supporting cells such as stela, you got immune cells in there. And so it's crazy, it all comes back. And so if you figure out how it is, then you won't have to work very much more after that.
All right, thank you so much for your time. We're at the end of our time today. Thank you so much, Dr. Kueht, for taking time out of your busy schedule to join us. For our audience to receive a certificate for this session, you must pass the quiz on our website, which is now uploaded. Be sure to join us next week for our next virtual shouting session with Ms. Nesky on August 11th at 7 p.m. Central. And as always, thank you, Dr. Kueht, for your time. Have a good night, everyone.